Hi, everyone. Thank you to the IGSC Organizing Committee for asking me to give this talk. It is my pleasure to update you all on the development of a clinical practice guideline for glycogen storage disease type 4, including the adult onset form, adult polyglucosan body disease, or APBD. For disclosure, this GSD4 guideline was funded in part by the Association for Glycogen Storage Disease. So clinical practice guidelines in the GSD space are nothing new. In fact, there are multiple guidelines that address the diagnosis, management, and treatment of GSDs, including for GSD 1, 3, 6, and 9, and most recently for 5 and 7. These guidelines are designed to address all aspects of the GSD specific care, including the journey to diagnosis, key approaches to management, and considerations for treatment approaches where applicable. This guideline is also a critical educational tool that can be used for the patients, their families, as well as the community at large. Given the utility of these guidelines, the U.S. Association for Glycogen Storage Disease, or AGSD, initiated the development of a clinical practice guideline specifically for glycogen storage disease type 4. This will include the adult onset form, adult polyglucosan body disease, or APBD. So just to back up and have a bit of a background, GSD type 4 is caused by the deficiency of glycogen branching enzyme. You'll hear me refer to this as its acronym GBE. The deficiency of this enzyme causes impaired glycogen synthesis, meaning the creation of glycogen is impaired, but the enzymes involved in gluconeogenesis, meaning the synthesis of new glucose from non-carbohydrate precursors, is still intact. Rather than the normal spherical glycogen being formed, insoluble, elongated chains resembling amylopectin are formed, and we refer to these bodies as polyglucosans. In just a moment, I will show a visual of this to help you keep track of these different steps that I mentioned. So GSD type 4 accounts for only 3% of all glycogen storage diseases, so it's considered ultra rare. And today, unfortunately, regardless of the presentation of GSD type 4, there are no curative strategies. Patients are managed based on their symptoms, and organ transplant is often needed depending on the severity and tissue affected. So here's an animated figure of the glycogen synthesis pathway to help you visualize this process that I mentioned. So in standard glycogen synthesis, we start off with glycogenin, which self-glycosylates and adds these initial glucose residues, which primes glycogen synthesis. From there, glycogen synthase comes in and acts as a glucosyltransferase, and it adds 10 glucose molecules approximately to that glycogenin core via alpha-1,4 linkages. And this forms that linear chain that you see here. From there, branching enzyme, or GBE, cleaves an alpha-1,4 link segment from that outer end of the glucan chain. So that's shown here in these dashed circle. And that is then transferred to form a branch point via an alpha-1,6 linkage, and that's highlighted here with that orange color. From there, glycogen synthase and the branching enzyme work synchronously to continue to form this branched spherical glycogen, which is soluble and stored in our cells for reserves of glucose. However, in GSD type 4, the deficiency of GBE instead leads to the continued action of glycogen synthase. So what we end up is with this polyglucosan that has long, linear, and tangled glycosyl chains. These formations are considered to be insoluble and lead to cellular dysfunction, and the consequences of which depend on what tissue they're in. So even though GBE, or glycogen branching enzyme, is the culprit here, we have to think, and intuitively we would think that GSD type 4 would have a specific and relatively predictable disease course, given that the culprit again is this GBE deficiency and polyglucosan formation. However, we see significant variability in the presentations of glycogen storage disease type 4. Over the past few decades, a subtype classification system was proposed. So this includes a fatal perinatal neuromuscular subtype. This onset would be in the perinatal time period, and it typically is associated with decreased fetal movement, arthrogryposis or contractures, global hypotonia, and typically death by the neonatal period. Next, we have the congenital neuromuscular subtype. This is similar, with the onset being less than 2 months old. Typically, these infants present in the newborn period with hypotonia, respiratory distress, dilated cardiomyopathy is possible, and typically there's death in early infancy. Now, These two that I mentioned here, so fatal perinatal and congenital subtypes, are often combined into one because, as you can see, it can be difficult to differentiate between the two depending on when questions are asked, when symptoms present. But all in all, the outcome is typically fatal. We next have a different subtype. So this is what we call the classic or progressive hepatic subtype. Typically, onset is within the first 6 months of life. Infants often appear normal at birth, but then slowly exhibit failure to thrive, hepatomegaly. Patients can present with progressive cirrhosis. Some do have hypotonia or cardiomyopathy. And typically, there's death by 5 years without liver transplant. There's also a form called the non-progressive hepatic subtype. This has onset in early childhood with hepatomegaly, liver dysfunction. There could be myopathy or hypotonia, and the patients are likely to survive without progression of liver disease. Now, I will say caveat, this one is much less documented. We're still learning much more about these patients. But this is how we classify them so far. So for hepatic subtypes, if you require a liver transplant or progress rapidly to liver cirrhosis and liver failure, we typically classify patients as this progressive or classic subtype, whereas those that do not require liver transplant and do not progress to liver failure are coined the non-progressive hepatic subtype. Next, we have the child, also referred to as juvenile or adolescent neuromuscular subtype. This is for patients that have an onset within childhood or adolescence. Typically, it's predominantly neuromuscular with myopathy. It can lead to mild or severe disease progression. There could be cardiomyopathy present, and there could be possible death in early adulthood. And lastly, on the other end of the spectrum, we have adult polyglucosan body disease, also referred to as APBD. This has an onset in adulthood, typically mid to late adulthood. The most common presenting symptoms are neurogenic bladder, peripheral neuropathy, leukodystrophy, gait alterations. There could be altered cognition, slurred speech, or dementia. And it's often frequently misdiagnosed, typically as MS, but also as ALS or urologic dysfunctions, given the symptoms. Now, for those of you who are more aware of GSD4, you've often heard it referred to as Anderson disease. Now, we're stepping away from this just because it encompasses this whole spectrum. But typically, when those were referring to Anderson disease, they were typically applying that to the hepatic subtypes, typically found in children. Whereas APBD has been noted again for this adult polyglucosan body disease in mid to late adulthood. So just to address the differentiating features between Anderson disease, so-called, and APBD. Now, to better understand the utility of this subtype system, Bridget Keeley from Duke University recently performed a systemic literature review on all published youth onset GSD4 cases, meaning those with onset of symptoms in the first 24 years of life. So to note, this does exclude adult onset APBD patients, given the difference in onset and also presenting symptoms. She found that 61% of these patients did not correspond fully with any of the established subtypes. Moreover, not shown here, 39% of those fell into the traditional category. So only 39% fit those traditional hepatic or neuromuscular involvement subtypes. 45% had two systems involved, meaning neuromuscular, cardiac, or hepatic, and 22% had all three involved, so neuromuscular, cardiac, and hepatic. This work was recently accepted for publication in Frontiers in Genetics, and you can find out more information on this study in Bridget Keeley's oral presentation here at IGSD. Now, these findings correspond with what we see a lot in our patients. And I bring this up because we're intentional in this guideline that we consider all presentations of GSD4, not just those that fit with these subtype classifications, because here we see that there are plenty and many that do not fit in these subtypes. So we're keeping in mind those that have a mix of presentations, those that have, it could be less reported on, such as those with a cardiac only phenotype. And moreover, GSD4 is considered in general to be underreported, and therefore the literature may not represent all of the patient presentations that are possibly out there. Notably, there are patients, multiple that we're aware of, that present with the lethal perinatal and congenital phenotype that I described, meaning again, present at birth, if not before birth, and require respiratory support and NG tube. But these patients instead do not require respiratory support. They do not require a feeding tube. And so it's important that we consider these patients in this guideline and we keep this broad enough that we're encompassing all patient presentations, not just those that, again, fit this subtype, this strict subtype system. And we don't want to accidentally exclude patients because we keep it too specific. Moving on to the other side of the GSD4 spectrum is adult polyglucosan body disease, which is considered the adult form or adult onset form of GSD4. So the APBD Research Foundation estimated that there is a prevalence of APBD being 3,400 for Ashkenazi Jewish populations over 50 years of age in the US. So that means 3,000 or so, whether it's diagnosed officially or not, they estimate that there are those amount of patients out there, at least in the US. Next, the presenting symptoms are commonly, like I mentioned, progressive neurogenic bladder, altered gait, and peripheral neuropathy. Now, these initial symptoms that I describe are very similar to other neurodegenerative diseases, and so therefore it makes it difficult to diagnose. So because of this, unsurprisingly, there's a high misdiagnosis rate due to the lack of awareness of features characteristic of APBD. And so those will be mentioned in this guideline, but we do want to call out attention that MS, ALS, cerebral small vessel disease, benign prostatic hyperplasia, and peripheral neuropathy are all common misdiagnoses for APBD. And even, more unfortunately, because of these misdiagnoses, these patients will often receive inappropriate therapy, such as MS disease-modifying therapy that will have no effect on their APBD disease, but will unfortunately put them through that treatment, which can be rather unfortunate. The average diagnostic delay is 6.8 years. And so I bring this up because we want to make sure that in this guideline, we're incredibly clear about how APBD may present similarly to other neurodegenerative diseases. Given that this is a rare disease, MS clinicians and other neurodegenerative clinicians are not necessarily aware of APBD. They often are not. And we want to make sure that this draws awareness and attention to how to diagnose APBD and then how to appropriately manage it. So all in all, for this guideline, the goal is to develop a practical resource tool for clinicians and patients that will address the following issues by highlighting current best practice and therapeutic consensus. So there's currently no management or treatment guideline for these patients. That's the need here. And youth onset GSD4, meaning that presenting within the first 24 years of life, and APBD, again, the adult onset form, are complex genetic disorders and have heterogeneous presentations, making diagnosis and treatment extremely challenging. Ideally, the language of this guideline will be suitable for an educated patient, as well as their primary physician. So the primary audience here is going to be our hepatologists, our neurologists, any neuromuscular specialists, urologists, medical geneticists, pediatricians, and primary care providers. So those that are seeing the patients day in, day out. However, though, we also want this to be for the secondary audiences. So emergency physicians, family members, community at large, like teachers or social workers. So we really want to look at this from two lenses. For all patients, regardless of age, this can be something that the clinician can find and use in the diagnosis and management of their patients. And for the patients and their families, this is something that you can provide to your providers who are assisting with your care and management. And it can also be something that you provide to the community at large. So this can help bring awareness to the disease. So the search for experts began in July of 2021. So unsurprisingly, as many of you know who are probably watching this, there aren't all that many experts that have treated GSD4 patients. We really have to go out and search for them. And that's also why we have this guideline, right? We want patients to not have to travel to these experts that have seen multiple GSD4 patients and are familiar with the best approaches. We want this guideline to reflect their expertise, so that way they can bring this to their local physicians or their local clinicians and receive still adequate care. So, like I mentioned, in July 2021, the search for experts began. Given that the care practices may vary by country, we limited this to United States only based guidance and experience, but we of course expect that the overarching principles and guidance of this guideline can be applied outside of the US. So we needed to find experts for all phenotypes of GSD4, meaning all types of presentations, and the end result was 20 experts. And so they all have expertise, or individually have expertise, in medical genetics, pediatrics, hepatology, neurology, cardiology, physical therapy, urology, genetic counseling, dietetics or nutrition, diagnostics, enzymology, and lastly, pathology. So first, we had our initial group meeting. So right after the new year in January 2022, each expert was assigned a specific writing and presentation section based on their individual expertise. We met via Zoom, and each person then presented on their section and pulled from primarily the literature, but also their own patient care experience. So pictured here are some of these experts, but definitely not all, as we all could not fit on one screen. But just to give you an idea, and this meeting was multiple hours long. From there, separately, we also met with the patients themselves, as well as advocates such as parents, caregivers, spouses. And these people were gracious enough to give us insight into what they would want out of this guideline and what parts of their healthcare they felt needed to be addressed. This process is absolutely critical. We absolutely wanted to include patient and patient advocacy discussions because it gives us a real insight into the patient perspective, into what's important to them. We ultimately want this guideline to be to the benefit of the patients. And so it was absolutely essential that we had these meetings. So there were many more that were not pictured here, but these are just some of the images of the recordings that I was able to gather. So thus, the GSD4 guideline was created. And so it includes background and the clinical variability description, so much of what I just mentioned, but in more detail about all the different presentations, the background of GSD4, and how these patients can really present and the variability we need to keep in mind. It also includes steps to diagnosis. So we're including differential diagnoses, so highlighting common misdiagnoses, but also those that need to be ruled out when considering a GSD4 diagnosis. We also include clinical and laboratory evaluations, as well as the diagnostic testing steps. So this is going to include molecular analysis, biochemical analysis, as well as the role of histopathology in making a GSD4 diagnosis. So also include the many facets of the medical management. So again, we have a lot of patients to address. We have those that only have hepatic involvement. We have those that only have cardiac or neuromuscular involvement. We have APVD patients. We have those that we, again, need to address all in one guideline. And there are so many similarities. So it does go hand in hand, but we want to make sure we devote enough individualized sections to make sure we are not lumping all together and we're addressing all the different presentations that can come along with this. So we have medical management for hepatology, cardiology, any organ transplant considerations, so namely for liver and or heart transplant. We have neurology sections, urology, physical and occupational therapy, the role of those two in the care, growth and development considerations, more for our children, fatigue and physical activity for all stages of life, psychology, absolutely essential that we address this, given the impact on the psychological role that rare disease can have, care, coordination and support, genetic counseling and family planning, nutrition care and glucose control, medical and supplement considerations, as well as highlighting knowledge gaps and future research directions. So from start to finish, this is what the creation of the guideline looks like, or what it involves at a bird's eye view, a larger lens. So first, writing assignments were created based on expertise and experience. After multiple meetings, this fostered more and more discussion, and so there was more revision. And so we had the individual writing assignments. Those written sections were submitted, again, compiled, more and more revision and discussion. So this continued on many, many times until each part of the guideline was agreed upon, clear and concise. In a few months, the final version will be submitted for publication, but first, the U.S. Association for Glycogen Storage Disease and the APVD Research Foundation will review this guideline prior to that. And once it's submitted, it will go through a rigorous peer review process. Sorry, my animation was slow there. So there's the APVD and AGSD icons and logos. And so there, again, we hope to submit this in fall of 2022, where it will then go through a rigorous peer review process, and fingers crossed, after that, it will be published for you all. So you can keep a lookout for the GSD4 guideline in late 2022 or early 2023. We do plan for this guideline to be open access, meaning it is open to all. You don't have to be part of a specific institution to access this. We want it to be accessible to all people. And this is just a call for better understanding for the natural history of GSD4. So Duke University does currently have a GSD4, including APBD natural history study that is actively recruiting. I list the clinical trials ID there for you all if you want to pull it up. The PI for this is Dr. Priya Keshnani. And as of August 31st, 2022, we have 14 countries included in this, compiling to 44 patients. I really do emphasize we learn so much from each individual patient. Even if you see that your country is highlighted there, but you know that you are not involved in this study, I encourage you to reach out. Every patient is unique. Every patient we learn a lesson from. So again, this does include both children and adults with GSD4, so including APBD. And our contact information is listed at the bottom there if you are interested in enrolling, or if you know a family member or you have a patient that is affected by GSD4. This also does include decedents or deceased subjects. So if you know of someone who unfortunately succumbed to this disease, again, please reach out. We are able to include them in this study. So this is just an acknowledgement to all of those that are involved in the consensus development panel. So all of those experts that I mentioned, and they're listed there. This work also couldn't have been possible without the help and support of additional team members, Leticia, Gata, and Jenna. And most importantly, truly, all of this, we have to give thank you to our patients and their families for being open about their experience and for sharing their stories and their journeys. Again, thank you to the AGSC for funding this project, and to the APBD Research Foundation for their support and for sharing this initiative to help us make sure that the APBD perspective is always included. And lastly, this is just a dedication to those that we have lost. Their memory truly does push us every day to continue this work. Thank you for attending this talk.